So to proceed with the talk, the next topic for neurodegenerative diseases would be kept under the umbrella of alpha-synucleopathies, and the most important amongst them would be dementia with Lewy bodies, and its sister diagnosis, Parkinson's disease dementia, which I'll be talking about, and a third, much rarer one called as multisystem atrophy. So case number 4, Mr. R, a 70-year-old retired accountant, presents with a 2-year history of fluctuating alertness, vivid visual hallucinations, and progressive slowness in daily activities. His wife reports that he often describes seeing small animals in the house and becomes anxious when reassured that they aren't real. Over the past year, he has developed marked postural instability with several backwards fall, as well as episodes of fainting and brief unresponsiveness. So this history tells us that there is fluctuating alertness. When we say fluctuation, there are 3 main things that we highlight in the history. One is fluctuation alertness in terms of whether they're drowsy in the day when they're not supposed to be, fluctuation in attention where they're listening to you but they zone out and then they come back to you. And the third one is fluctuation in word finding difficulties. So sometimes they're speaking to you normally and suddenly they have a word finding difficulty spell, and then sometimes they're back normal again. So this is how they typically describe the symptoms of fluctuations in dementia with Lewy body. Then another thing to highlight here is the constellation of symptoms. So there is movement disorder, there is visual hallucinations, there is fluctuations in attention, and there is an autonomic dysfunction here which is causing fainting episodes as well as syncope. So he complains of excessive daytime sleepiness, a diminished sense of smell, and chronic constipation. Again, these are hallmark features which can talk about brainstem involvement and the vagus nerve involvement, which can be because of alpha-synuclein acting in a prion-like spread manner. And there is urinary urgency which has progressed to occasional incontinence. Cognitive testing shows fluctuating attention and slowed thinking with relatively preserved recall. And attempts to treat his hallucinations with low-dose antipsychotics has led to severe rigidity, worsening confusion, and promptly discontinuation. So what I'm trying to highlight there is the neuroleptic hypersensitivity phenomenon that can be seen in dementia with Lewy body, where the older types of antipsychotics, if they are given, they can precipitate Parkinsonism and make them even rigid and stiff, which makes you discontinue the medication that you are trying. So this, in essence, is the flavor of a dementia with Lewy body presentation. His wife also complains of him acting out his dreams, which is REM sleep behavior dysfunction, and it has increased over the past 6 months, which has made them now sleep in separate rooms. So on neuropsych testing here, we see that there is higher variations and variability in task performance as digit span scores. What I mean by that is, suppose the person has been in your clinic today and you do the digit span test and you time them. They could maybe do the digit span in, say, 1 minute. Next time they come into your clinic, you do the same digit span, it could be 1.5 minutes. And it could be tomorrow, it could be day after tomorrow. So that fluctuation in timing of doing the digit score will objectively document fluctuations on your cognitive testing. Then there can be visuoperceptive impairment, where in this Hooker's test, you try and make a sense of all the 4 parts and say that this is a baseball, or this is a cup, or this is a shoe, and this is a lighthouse. But the person here has just talked about the seam. He has not seen the whole. So rather than seeing the forest, they are seeing just the tree. So this is visuoperceptive impairments, as well as visuoconstructive impairments, where you can see that the Necker's cube, the person is struggling to draw a 3-dimensional image of it, and the same with the interlocking pentagon and their ability to draw a clock. So they do have memory impairments, but the memory impairments may not be the predominant presenting feature of this phenotype. So what is the diagnostic criteria for dementia with Lewy body? So the caveat here is Lewy bodies can present at an earlier stage as well. So that would be called as mild cognitive impairment stage. So when we use the word dementia, we are implying explicitly that there is a change in function in at least 2 or 3 cognitive domains, and there's a loss of IADLs for the instrumental activities of daily living. And along with that, the core clinical features are recurrent visual hallucinations, fluctuating cognition, attention, alertness, REM sleep behavior disorder, and Parkinsonism. So Parkinsonism are largely 4 symptoms: postural instability, tremors, slowness, and falls. So if you have 2 or more symptoms, you would tend to call them that they do have Parkinsonian features. And some indicative biomarkers that can be done to confirm this diagnosis are a DAT scan or a dopamine scan to show if they are taking up dopamine at the receptor levels. And you can also do a polysomnogram to show whether the REM sleep time, whether the person is having atonia or not having atonia. So a lack of atonia would mean that the gatekeepers have gone away and they are acting out their dreams and thrashing about. So doing a polysomnogram in these patients might yield this evidence for a synucleinopathy. And also doing an MIBG scan would also show the autonomic regulation of the heart, and that could also be an indirect or a confirmatory test for dementia with Lewy body. So for a probable diagnosis, there should be 2 or more core features along with the presence of an indicative biomarker, or 1 core feature and 1 or more indicative biomarkers. So, right.
Explain that, they may not know about MIBG.
So MIBG scan is a scan which helps tell you about the autonomic innervation of the heart and the autonomic nervous system. So because I mentioned in the clinical story that they can have a lot of autonomic dysfunction, they can present with that.
This is the functional scan that's available, and I did a fair bit of those when MIBG was coming from BRC, and now suddenly they've stopped. So Vikram's no longer doing them, but we did a few of them before Aditya came along. So what is striking in Lewy body disease is that not only is there this degeneration producing Parkinsonism and the fluctuating problems and REM sleep behavior disorder, but they have a demonstrable dysautonomia. So they are susceptible to autonomic dysfunction. So this MIBG, when you give beta-iodobenzyl guanidine, normally the heart takes up in a very robust way. In a normal person, the heart is rich in autonomic innervation as expected because it's beating all the time and it needs a lot of autonomic regulatory framework. So it's very hot on that MIBG. And if you did an MIBG in these people, the heart is kind of awakened. It just doesn't go there in the thoracic cavity. And you can actually see it. So it's a very graphic image, but it's not available in Mumbai anymore.
Yeah. Even in Calgary, we hardly did much scans for MIBG. Even in Calgary, we didn't do much scans for MIBG.
This is all how it comes as a fashion and it goes. For sarcoid, we used to do a different kind of scan. Now we don't do it. Now they do FG PET.
So some of the supportive features pointing towards a diagnosis of dementia with Lewy body would be severe sensitivity to antipsychotic agents, postural instability, repeated falls, syncope, severe autonomic dysfunction, hypersomnia, hyposmia, hallucinations, and systematized delusions, apathy, anxiety, and depression. So how do we manage this difficult diagnosis is by prioritizing their symptoms. What is the most distressing symptom to the patient? Whether it is the movement disorder of slowness or whether it is the visual hallucinations, which is very distressing. Because if you tend to prioritize the movement disorder and you start giving them levodopa, then that can worsen their psychosis. So you have to ask the person of all the symptoms that you are having right now, what would you like us to control the most? So if they say we want the visual hallucinations treated, then the options that we can give them is, first, you should put them on an acetylcholinesterase inhibitor and preferably rivastigmine. If it's a patch form, the better. That definitely helps control a lot of visual hallucinations.
Yeah. So the odd thing is the Japanese have shown this, that if you take brains of patients with Lewy body disease, their cholinergic deficit is 10 times the cholinergic deficit of Alzheimer. So rivastigmine was made by Novartis as Exelon in the early 2000s when it got launched for the therapy of Alzheimer's disease. But then lo and behold, if you have a patient with cognitive impairment, you give them the rivastigmine patch, and the relatives come and touch your feet after 1 month and say, "Arey, Doctor Sahab, jadoo ho gaya." You know, he's very good now, then it doesn't have Alzheimer. They're very good now is Lewy body disease. So the cholinergic deficit is so dramatic that when you give them an acetylcholinesterase inhibitor, they are remarkably better. So I had a patient like that close to Reliance. He used to live next door to the Reliance building, Mr. Merchant, and he went for a holiday to Houston, and the families were completely ecstatic that how come their father, who was so obviously not in control, became so good. But it lasts for a while. So this input from rivastigmine lasts for a few years. And then with the passage of time, the brain does fail. And that can be over 5-6 years. It's a very typical thing. So the Japanese have shown that the cholinergic deficit is 10 times. It's worthy of knowing.
Agreed, sir. And on top of that, if still the symptoms persist, then we can try lower doses of quetiapine and clozapine. Yeah. And now there's a newer drug, pimavanserin, which is a 5-HT21A inverse agonist and an antagonist without any effect on the dopamine receptor. So there are few case reports, pimavanserin versus quetiapine for the treatment of psychosis in Parkinson's disease and dementia with Lewy bodies. So in this, there was no statistical difference between quetiapine and pimavanserin. However, it was trending towards some improvement of symptoms with pimavanserin. So you can see that 65.2% in the quetiapine cohort had symptom relief, whereas 75.6% in the pimavanserin cohort
More
had.
More died on quetiapine.
Pardon?
More died on quetiapine.
Yes, more died on quetiapine. So 7 patients out of 46 died and 3 out of 45 died in the pimavanserin part. So pimavanserin seems to be safe, but the difference is still not statistically significant. It could be because the study is underpowered, but there is no harm, I think, in off-label trying to use pimavanserin in dementia with Lewy body. And that is what this case series talks about. So in 4 patients of DLB, they had tried clozapine and quetiapine, and they did not work for them. They precipitated Parkinson's features. So because of that, they shifted to pimavanserin, and the results were good, and they were efficacious, and it helped resolve their visual hallucinations. So because of that, there is still need for a larger study, which is randomized control trial to advocate strongly for use of pimavanserin. But because it is available in Mumbai right now, I think it is something that off-label can be tried in patients with dementia with Lewy bodies. So how to conceptualize DLB, dementia with Lewy body, and Parkinson's disease dementia and Alzheimer's? So Parkinson's disease dementia would largely have an alpha-synuclein based neurodegenerative disease. And as we go towards the spectrum of dementia with Lewy body, at autopsy you tend to have a combination of both alpha-synuclein as well as beta amyloid positivity in their neurodegenerative profile. So that is something, another way to visualize this would be Parkinson's disease would start in the brainstem and then extend outwards to the cortex, whereas dementia with Lewy body would start in the cortex and then descend downwards to the brainstem. So in the classic textbook definition, they would say that if cognitive symptoms arise 1 year before the onset of motor symptoms, then you would lump it under dementia with Lewy bodies. If the Parkinson's symptoms arose first, followed by cognitive symptoms 1 year later, then we would call it as Parkinson's disease dementia. So that is how we would conceptualize that. So moving on to the next case, Mr. K, a 72-year-old retired teacher, has had Parkinson's disease for the past 8 years, and that was characterized by bradykinesia, resting tremor, rigidity, and gait freezing. And initially, it was well controlled on levodopa. Now, over the past 18 months, his family notes progressive forgetfulness, difficulty following conversations, and trouble managing finances. So we can see that there is a failure in cognition happening in episodic memory as well as in planning and execution. He misplaces items and struggles with planning and visuospatial tasks, example, navigating familiar places. His wife reports that he occasionally sees small animals or people in the room, well-formed visual hallucinations, though he retains partial insight. Fluctuations in attention are mild but present. No early hallucinations or cognitive changes were noted before motor symptom onset. So this kind of profile overlaps that of dementia with Lewy body, but because the motor symptoms predominated the scenario for more than 8 years, this would be labeled as a Parkinson's disease dementia. So when it comes to the neuropsych testing pattern for alpha-synucleopathies, there are attentional deficits and severe slowing in executive tasks. Word fluency is again reduced, but here it's the phonological fluency which is reduced. So in essence, in Alzheimer's, to remind you, I said that the semantic fluency is reduced. You ask them to name a list of animals, they get impaired there. Whereas in these patients, they're able to do that well, but they struggle to come up with words starting with the letter, say, D or F. So that's the change here. Again, there are visuoconstructive functional deficits, working memory impairments, and impaired delayed recall, but relatively intact recognition. So unlike Alzheimer's disease, where they will confabulate and misremember items, these people tend to recognize what was given in the list, although they cannot recall it offhand or freehand. So this is an interesting recent paper again in 2025, a data-driven characterization of distinct cognitive subtypes in Parkinson's disease dementia. So they have lumped these two together, and those who present predominantly with memory deficits, episodic memory changes, out of 75 patients, 50% came under memory deficits. And the second lump was visuospatial deficits. So the only highlight that I wanted to point out here is that the visuospatial predominant cluster B, they had a higher prevalence of GBA mutations and hallucinations. Otherwise, there was no difference in the outcomes or prognosis for them, but it might guide individualized based treatment if in the future we do have any management issues for GBA mutations. Pardon, sir? Yeah. So GBA is a glycocerebroside protein which helps in the clearance of alpha-synuclein, and any gain of function mutation there would lead to accumulation of alpha-synuclein, which will drive the oligomerization and the Lewy body formation. So a GBA mutation is an inherited, one of the most common mutations that we can see in dementia in Parkinsonian patients.
So let me simplify it.
Yeah.
The simplest thing is we discussed in the first talk that waste removal is autophagy. And autophagy is how the brain cell throws out stuff which is potentially harmful. So you need workers to do that. GBA, glucocerebrosidase, is a worker. And if you have normal amounts of GBA, that means glucocerebrosidase levels are good, and you don't have a mutation, then these workers are industrious, and when you're sleeping at night, the autophagy is going to occur. And if you have good REM sleep, then it's going to occur, because autophagy requires REM sleep, and there's a complex way that happens. So the stuff gets cleared, synuclein gets thrown out, and the brain remains good. If you have an abnormality in the GBA, and many Parkinson patients have mutations in GBA, many Lewy body patients have mutations in GBA, and there are many other mutations, and it's a different story by itself. But essentially what it's saying is that waste removal is dysfunctional because a key element in the waste removing biology is odd, right? He's a weak bloke and he doesn't do his job properly. And that's why synuclein doesn't get pushed out.
That is new learning for me as well. I didn't know that. Yeah. Thank you.
So there's some phenomenal things happening in the genes.
So when it comes to managing Parkinson's disease dementia, we would put them on levodopa and dopa agonists as and when required, and we would avoid any anticholinergic medications to prevent them from having any cognitive symptoms. And we can give them a trial of acetylcholinesterase inhibitors like rivastigmine more than donepezil. The evidence is more for rivastigmine. And if they have mood changes like depression or anxiety, trying SSRIs would definitely be helpful, as well as using pimavanserin, because FDA has approved pimavanserin to be used in Parkinson's disease-related hallucinations. So although this is Parkinson's disease dementia, it still has new recent evidence which allows you to use pimavanserin in it. So this was a paper, a subgroup analysis of the Harmony trial. Harmony trial was for talking about the use of pimavanserin in all types of dementias, and this paper looked at only the Parkinson's disease dementia subgroup. Yeah, and they did point out that it was well tolerated and did not worsen motor or cognitive function, and there was about a 64%. Yeah.
That is cloak speak for it did work in many.
Yeah, so not in all types of all-cause dementias, but for Parkinson's disease dementia, it may have definitely shown some improvements. So that's why I have not included that in management of hallucinations in overall dementias.
I don't think it helps in Alzheimer's disease.
Yeah, I agree, sir. No.
Psychotic symptoms in Alzheimer's and give them pimavanserin doesn't.
No, yes, sir. Only for the synucleopathies.
Doesn't do much.
Yeah. So moving on to the next synucleopathy, the last one. So Mr. R, a 58-year-old man, presents with a 2-year history of progressive slowness of movement, stiffness, and imbalance. His wife reports that he developed urinary urgency and occasional incontinence a year before the motor symptoms began, followed by lightheadedness upon standing. She also complains about his loud snoring at night and occasionally acting out his dreams. So we can see that there is an extrapyramidal possibly involvement, a progressive slowness of movement, and stiffness. Stiffness could be an indirect marker of, say, pyramidal dysfunction, and there is imbalance, which may or may not be a neuropathy or a cerebellar involvement. The urinary urgency and incontinence can be an ancillary symptom of autonomic dysfunction, and there is lightheadedness which goes along with that. There is loud snoring, possibly stridor, and occasionally acting out his dream, again suggesting some REM sleep behavior dysfunction. So in essence, it is involving multiple systems of the nervous system, and on examination he has bradykinesia, rigidity, mild postural instability, again pointing towards extrapyramidal symptoms with minimal response to levodopa therapy. His speech is slow and strained, and he shows some gait ataxia with broad-based steps and a mild limb dysmetria, pointing towards a cerebellar involvement on examination. And that is what we would say is a typical hallmark of multisystem atrophy or MSA. And we can see in this example, courtesy to the residents of Sion Hospital, where a person lying down has a blood pressure of 138/92 with a pulse rate of 79. And at the end of 3 minutes, the systolic blood pressure is 80 and the diastolic is 55 with an increase in the heart rate, a compensatory increase. So any systolic drop of more than 20 and a diastolic drop of more than 10 would point towards a diagnosis of postural hypotension, which is a marker for autonomic dysfunction. We can also see that the person here in the white apron is slightly tilted towards the right, which is also called as a Pisa sign, so the Leaning Tower of Pisa. That can also be a hallmark sign of multisystem atrophy. So on neuropsych testing, again the phonological fluency is a little reduced. Memory deficits are less pronounced than executive dysfunction. The FAB scores here are more impaired and at earlier stages of the disease. So if you were to screen patients for cognition in a suspected case of MSA, we would go for a FAB test over a MOCAR and MMSE. And they exhibit impaired performances in the trail making B and Stroop test. So again pointing more towards the frontal subcortical involvement in an MSA kind of picture. So how do you suspect possible prodromal MSA? So there can be non-motor features of urogenital failure or a neurogenic orthostatic hypotension and REM sleep behavior dysfunction, and some subtle Parkinson's and cerebellar signs. For a clinical probable diagnosis, there should be autonomic dysfunction documented objectively with a post-void residual volume and urinary urge incontinence and a documented drop in postural hypotension, along with a cardinal feature of Parkinson's and ataxia, and then you can have supportive motor or non-motor features. So in clinically established MSA, there will be a post-residual void residual volume of more than 100 ml, along with documented postural hypotension and ataxia and levodopa unresponsive Parkinsonism, with MRI markers of hot cross bun sign and other signs which will be demonstrated later. So the main pathology here in multisystem atrophy is the accumulation of synuclein clumping called as Lewy bodies inside the supporting cells, the glial cells, the oligodendrocytes. And that is the difference between MSA and Parkinson's.
So this is what I was talking about in the beginning, that we thought that the glial cells are only glue, but that is not true. They have an important role to play in normal neurophysiology of normal functioning of the brain. So you saw these other two synuclein disorders, Parkinson's disease and Lewy body disease, where the alpha-synuclein is clumped into neuronal cells. Here this is different. The alpha-synuclein is clumped into the oligodendrocyte. And yet there is a devastating change in the efficiency of neuronal functioning in many domains: movement, balance, autonomic system, sleep. So they often have REM sleep behavior disorder. In fact, that can be the starting thing. There used to be a researcher called Plazzi in Bologna. So they had taken people with REM sleep behavior disorder and followed them up over 10 years, and a large number of them developed multiple system atrophy. So it can start from a sleep disorder and then can go on to develop the other motor problems. Besides the snoring, they often have stridor at night. So when they are sleeping, instead of snoring, they are making noises like you can actually hear the stridor because their larynx contracts in sleep. It's a very peculiar disorder, and not much was known about it. All that we learned about it came, I think, when I was a student in 1990. There was a supplement in JNNP published from Queen Square, the person who was the research fellow went on later to become the head of the department after David Marston. And till then, we didn't know what was, when we were a student, that was the first time that this MSA got elucidated in neuroscience. And we are still so many things that we don't know. We don't know why this happens. There are no genes to my knowledge. The MSc has no genes, right?
No, sir.
So to my knowledge, there is no sporadic or genetic predisposition. So why this thing in the glial thing, synuclein fails, we don't know. It's not been studied too much. So we know what it is, but we don't know why it happens.
So the management of stridor would be to help initiate them on a CPAP machine so that the stridor is taken care of, as well as the OSA component, if there is, can be managed. For the REM sleep behavior dysfunction, we can maybe consider clonazepam low doses or melatonin to help with the REM sleep behavior symptoms. For the autonomic dysfunction symptoms, for orthostatic hypotension, giving them stockings, suggesting that they take higher intake of salt, then making sure that the antihypertensive medications are titrated, then trying, say, midodrine or pyridostigmine can also help increase their blood pressure. And then for erectile dysfunction, we can try drugs like sildenafil. And for bladder dysfunction, based on the underlying etiology, appropriate medications can be started. And it has to be a multidisciplinary involvement because they can tend to have a lot of falls, and their Parkinson's features can be better trained by or managed with the use of OT and PT and environmental modification to prevent falls. So these are some beautiful images which show this position of Lewy bodies, and these are attached to the cells. They are in the oligodendrocytes. And this is a beautiful picture of a Lewy. Hello everyone. I think I'll start with my next case. So Mrs. S. Yeah. Mrs. S.
Let's keep it close to you. Yeah, now you're good.
Thank you. Sir is the perfect mentor. Thank you. So a 58-year-old retired marketing executive is brought by his wife for embarrassing public behavior and loss of manners over the past 2 years. Initially, he began making sexually suggestive comments to strangers and inappropriately hugging acquaintances. He developed a newfound fondness for sweet foods and alcohol, despite previously being health conscious. Over months, he became impulsive with money, donating large sums to online causes and buying gadgets impulsively. So in these 2 paragraphs, we get a sense that there has been a drastic change in personality. The person is no longer high-functioning individual that they used to be. There are a lot of judgment errors which they are making, and they are spending unnecessary amounts of money which initially they would not have done. Plus, there is this newfound love for sweet foods and alcohol, which indirectly points to a phenotype which is leading us to a diagnosis of behavioral variant of frontotemporal dementia. At home, he spends long hours watching television and fails to initiate chores unless prompted. So this might also be a form of apathy presentation where the person is not having any internal drive to get up and do things. And his wife notes that he still enjoys doing things when asked, but rarely starts them on his own. So there is some initiation issues. He denies any sadness, worry, or hallucinations. There are no major memory complaints, though his wife notes he often interrupts conversation and cannot read social cues. So overall, the flavor is more of a behavioral variant than any episodic memory loss or any other executive problems. So there is a family history of similar psychiatric changes. So far in all the cases, I had never added any family history comment. But for the first time, I have added a family history because in behavioral variant FTDs, about 20 to 30% of patients may have a family history, not necessarily of any behavioral variant symptoms, but they could have Parkinson's features, or they could have just hallucinations, or they could have paranoia. So any gamut of neurological or psychiatric symptoms in the family history would definitely be significant in this case. So an examination for such a patient, we would always look for any frontal release signs like a glabular tap, grasp reflex, palmomental reflexes, or pout reflexes, which can be elicited in advanced cases. There can be pyramidal or extrapyramidal signs which can come in different types of behavioral variant FTD. And the typical screening score to be done is again the frontal assessment battery, where a cutoff score of less than 12 out of 28 out of 18 would be acceptable, or a diagnostic point towards behavioral variant FTD. The caveat here is the MMSE should be 24. So the person is in general able to think and do things, but on a frontal assessment battery, the scores are on the lower side. There is again reduction in phonological word fluency, and the trail making test can be delayed. So what I am showing here is a very old battery called the Baron-Cohen's test, where they show different eyes and human expressions to these people with behavioral variant FTD, and they ask them to judge emotions. So another expanded version right now is called as the Ekman 60 faces test, and on this, disgust and anger is something that behavioral variant FTD patients are unable to identify correctly. So this again tells us that there is something organically wrong in their ability to assess human emotions. And this happens because of the involvement of von Economo neurons in the insular cortex. So the insular cortex is one of the most recent cortexes that we have. And the problem with developing animal models to study behavioral variant FTD is that not all animals have this insular lobe. So the only animals that we know of right now who have such kind of insular lobes and von Economo neurons are whales, dolphins, chimpanzees, and larger apes. So it is very difficult to study this, and elephants too, yes sir, to study this kind of disorders and to develop therapeutics against them. So how do we diagnose a case of behavioral variant FTD? So the person should be above the age of 50 years and should have a progressive disease, and there should be early behavioral disinhibition or early apathy. So I'm just going to read the criteria, and 3 out of this 6 should be there. So early loss of sympathy or empathy, early perseveration, stereotypical behavior or compulsive behaviors, hyperorality and dietary changes, executive and degenerative deficits with relative sparing of memory and visuospatial functions. And the person affected must show progressive deterioration of behavior and or cognition by observation or symptom history or as provided by a knowledgeable informant. So this is a caveat in the cognitive clinic, that when you see a person, one of my first lessons that I learned during my first week of fellowship was that the person sitting in front of me said, everything is fine, I'm good, everything is all good, there are no problems with me, I don't know why my daughter sent me here. And soon I realized with experience that a lot of people lack insight into their issues. So taking a very reliable collateral history is of utmost importance. And similarly here in BVFTD cases, because there is such drastic change in personalities, having it come from a very reliable informant is the key. They exhibit significant functional decline, so that qualifies them for the diagnosis of dementia. And the brain imaging results should show some form of frontal and or anterior temporal atrophy, either on MRI or CT, and frontal and or anterior temporal hypoperfusion or hypometabolism present in PET or SPECT imaging. So 3 out of these key symptoms, along with imaging modality and a progressive history, that would clinch the diagnosis for behavioral variant FTD. So now the only kind of cohort that we would usually send genetic testing in the cognitive lab used to be for these kind of BVFTD patients, and the only test that we would generally send for screening would be the C9 of 72, because that's the most common mutation which can run in families. So it's a hexanucleotide repeat expansion, and it can present with a motor neuron kind of overlap symptom with BVFTD. And some of these patients can have psychosis as well. So the underlying pathophysiology is a TDP43 pathology, but I won't go into those details now. The other common mutations are the MEPT mutation and the GRN mutation. So syndromically, I was taught to lump these behavioral variant FTD patients into 2 types for better counseling purposes. One would be the apathic predominant types, and one would be the disinhibited types. So in the apathic types also, there would be 3 different types. One would be the limbic type, where the person was insensitive to the spouse's needs or did not have any kind of empathy for the other people around them. And then there was an executive type difficulty, where the person knew that he wants to get up and go get the apple, but did not have the executive capacity to plan and formulate how to go and get that apple to eat it. So they would tell, I want to do it, but would not be able to execute it. Then there was another type of apathic cohort, where there was auto-activation deficit, where they were just sitting mindlessly and looking out. So I remember a patient vividly where the sister got the person in, and the complaint was that when she went to visit his house was littered with rat droppings and packs of chips just opened and kept, because he just didn't have the drive to get up and do anything. And he had lost a significant amount of weight and was only eating one type of food, that was chips, 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 and chips. So that kind of phenotype fits into a behavioral variant FTD situation. The toughest job, in my opinion, is how to manage these kind of symptoms which might be quite resistant to therapy. So those with apathy can be given or counseled to have a structured routine where the caregiver helps plan their day from morning to evening, and they have some kind of activities planned out, and that doesn't take too much of planning beforehand. So having weekly charts ready is something which helps them. Environmental modification can be done. What I mean by that is those people who are prone to gambling or prone to drinking too much or prone to eating too much of unhealthy food, you make sure that it's not stocked at home. If they're using their cards, then change the pins on the card, change the internet banking passwords, and make sure that the environment is modified so that they don't go out and cause harm financially to themselves or to others, or in other aspects, including making sure that if they go out into public and they have some kind of sexual disinhibition or they have other kind of issues, having a marker on them or a card which gives other people a diagnosis and tells them that if such a thing happens, to take the medical diagnosis into consideration before taking any action against them. These kind of small, simple tips can be done to help manage this kind of syndrome. Caregiver training is of utmost importance because in my experience, the most caregiver burden that I've seen in the clinic has been for the behavioral variant of FTDs, and that is because of the sudden drastic change in personality, which definitely takes a toll on the spouse. Maximum number of divorces in neurodegenerative disorders in the Western Hemisphere has occurred in the setting of behavioral variant FTDs, because these people are typically young as well. So they might be in their late 50s and very early 60s when they manifest such disinhibited symptoms. Physical exercise and training is a very important tool, because there are studies which I'll show in the next lecture about the influence of exercise on behavioral variant FTD with those cohort of people who already have known mutations and are carriers. I'll talk about that later. But giving them regular exercises gives them an outlet to remove all their excess energy and disinhibited drives and impulses. In terms of medical management, apathy can be treated or tried to be treated with methylphenidate and modafinil or amantadine. Disinhibition as well as stereotypic behaviors may respond to sertraline, citalopram, paroxetine. And if there is too much of aggression and mood lability, then valproate and carbamazepine can also be good options which have been tried in trials, but the data is not really robust. But there are a lot of clinical anecdotes where this kind of combination of drugs do, not combination, individual choice of drugs do work. And if there is sleep or impulsivity overlap, then melatonin or low-dose quetiapine can also be tried. So this is how the gross pathology looks like. We can appreciate the profuse sulcal widening and the frontal and the temporal poles being atrophied, which is in stark contrast to the occipital lobe, which still has a lot of intact sulci and gyri. So moving to case number 8, I think in the interest of time, I'll skip the case and I'll just go to the descriptions. So this was non-fluent variant of primary progressive aphasia. So this is also a type of 4R tauopathy. It also comes under the umbrella of frontotemporal degeneration, and it presents typically with agrammatism in language production. So they will be agrammatic, they will be effortful, they will have apraxia of speech. You can see them struggling to formulate the words and speak, although they know what it is that they want to speak. And they can be inconsistent, that is the verbal apraxia. There can be impaired comprehension of syntactically complex sentences. So longer sentences, they may not be able to understand. There is spared single word comprehension and spared object knowledge. So I'm going to show an easy graph to remember later on how to subdivide the primary progressive aphasias. So in the non-fluent variant, we can see that there is extremely thinned out, the perisylvian space has widened and the temporal lobe has thinned out. So this is where the pathology starts. In terms of prognosis, the prognosis of these disorders is generally better than behavioral variant FTD because the pathology takes some time to spread to the entire brain. So these patients might have a prognostication of around 8 to 10 years plus. So coming to another type of primary progressive aphasia, it is the semantic variant. where there is impaired confrontation naming. So if you ask them to name what is this, they're unable to name what objects we are trying to point out, and they tend to circumlocate and try to describe things in a circumlocatory way. There can be impaired object knowledge, especially for those items which we don't use regularly. For example, if I show them a harmonica and ask them, can you tell me what this is? Or I show them a trumpet and ask them what it is. They may not be able to describe its use very well. They can have surface dyslexia, like an example would be yacht. They will call it yacht, and examples like that. They can be spared repetition and spared speech production. So the lobe involved here is the anterior temporal lobe. So this is the part of our brain which stores the library of words and its meanings. So whenever the pathology involves the anterior temporal lobe, there is semantic variant of primary progressive aphasia as a manifestation. So this was the graph that I was talking about. On one axis, you assess a grammatism, and on the other axis, you assess word comprehension. So if the person does not have a grammatism but has word comprehension deficit, then it's a logopenic primary progressive aphasia. And the most common pathology involved here is an Alzheimer's type of pathology, an amyloid and tau mixed pathology. If it's an agrammatic presentation with intact word comprehension, then it becomes a non-fluent variant where there is perisylvian atrophy. And if the word comprehension is impaired and there is no agrammatism, then it becomes a semantic variant of primary progressive aphasia. So these patients will present more with language dysfunction and not primarily behavioral changes, but they can accompany each other. So the management of aphasias, there should be tailored speech language therapy. That is the mainstay. For those who have non-fluent variant of PPA, they should have motor speech and agrammatism training. So whenever they speak, the SLP will try and correct them and give them techniques to come back to the right word and the right pronunciation. They will give them oral exercises to help with pronunciation. Then melodic intonation therapy, trying to express themselves in singing voices, is also something that can be tried. In semantic variant PPA, semantic feature analysis. So suppose the person has like sandwiches. Sandwiches is part of the diet that they use, but they're not able to say the word sandwich. So you can train them to say different things, white breakfast item or some triangular cut item. So that kind of semantic feature analysis can help them circumlocute and convey what it is that they want to say to the caregivers. So in the logopenic variant of PPA, lexical retrieval and repetition practice along with script writing can work. Because their repertoire is less, you can have pictorial charts for them placed throughout the house. So they can point to the picture and express what it is that they want to say. And there are different apps which are available, but for a fee, where you can get all these features customized to yourself, to the person, and then the communication with the caregiver is enhanced. So this is one of the avenues for AI also to help adapt to the person's deficits, match it and improve over it. So coming now to involve some extrapyramidal cases, let's read the case and then come to a diagnosis. A 66-year-old retired postman presents with a 2-year history of frequent unexplained backward falls, progressive slowness of movement, and increasing difficulty in swallowing. So we can see that there is imbalance while walking, that there is a sense of slowness, extrapyramidal symptoms, and there is difficulty in swallowing as well. His wife reports subtle behavioral changes like emotional blunting, apathy, and occasional irritability. Over the past 6 months, his speech has become slow and effortful, and swallowing has become labored. So there are bulbar symptoms which are now manifesting. There is no family history and poor response to a prior levodopa trial. So it falls under the spectrum of an atypical Parkinsonian feature. Because if you look at the umbrella of Parkinsonism, idiopathic Parkinson's disease is the most common one, and one of the hallmarks of idiopathic Parkinson's disease is its levodopa responsiveness. So looking at this clinical phenotype, we can suspect that this is a progressive supranuclear palsy, and on examination we can see that they can have reduced vertical gaze saccades, more on the downward direction than to the upward direction. So here we can see that she's been asked to look upwards and downwards, but she's struggling to do so. So on the video it feels that she's just looking in front, but she's unable to look up or look down. And sometimes there can be a round the house sign, which can be seen on ocular examination. For this, you would need the volume. Is it possible to have a volume on to hear how she speaks? If not, we can just appreciate the procerus sign, where there is the procerus which is contracted, there is a mask-like faces, there is reduced blink rate. Here we can appreciate her gait, where she is dependent on a caregiver and is not able to walk independently. There is reduced stride length, and you can see that she has had a fracture, which is an ancillary sign for her frequent falls. Yeah. I think we can move on. So this is a pull test or a retropulsion test where we ask the person to maintain balance, and we pull them back, and they are not able to maintain balance in spite of repeated attempts and explaining that they need to try and maintain their balance. So the diagnosis comes into play when the symptoms are insidious in onset, gradually progressive, and the person is above the age of 40 years. The main hallmarks are oculomotor examination findings. So if there is a vertical gaze palsy or slow vertical saccades, that's a pointer towards oculomotor involvement. If there is postural instability, there is repeated falls, and the pull test is abnormal within 3 years of symptom onset, that also points towards a PSP phenotype. And akinesia, which is axial predominant. By axial, we mean that the central axis is more rigid compared to the appendicular rigidity. And cognitively, they can be frontal or dysexecutive function, along with apathy and impulsivity as their main BPSD features. So in terms of management, the Parkinsonism is very difficult to manage because they are not sensitive to levodopa. Though trials should be given, at least going up to 1,000 milligrams of levodopa per day should be tried. Rigidity and dystonia, it's very difficult to treat that, but Botox injections wherever required can be tried. Mood and apathy may be responsive to SSRIs. Sleep and fatigue, melatonin would be the safest drug to try in those situations. For excess salivation, which can happen in these people because of poor swallowing, giving them, you can try giving atropine eye drops in the mouth or glycopyrrolate or even Botox injections to the salivary glands. If there is dysphagia, then doing a PEG tube might help with feeding towards the end stages of disease. And this is a very difficult and challenging disease to treat. So having a multidisciplinary team approach for such kind of cases is an absolute essential, where working with SLP, OT, PT, social worker, fall prevention supports at home is very important to maintain quality of life. So on the gross pathology, we can appreciate that there is profuse midbrain atrophy in comparison to the fullness of the pons. So now coming to the second last case, a 62-year-old right-handed man presents with a 2-year history of progressive clumsiness and stiffness in his left hand. So it's asymmetric. He's not able to use his left hand well. Initially, he noticed difficulty buttoning his clothes and using cutlery. And over the past year, his wife reports involuntary, purposeless movements of the same hand, which sometimes seem to move on its own. This is often called as an alien limb phenomenon. He also struggles to find words and occasionally uses incorrect ones. So there is some kind of apraxia of speech also. The patient is trying to say something but is unable to formulate the words. He has been struggling with managing his finances and even calculating loose change when buying groceries. So there can be high parietal involvement where calculation is impaired, assessing objects in their hands can be impaired. And all these point towards an asymmetric parietal lobe involvement, which would be a classic hallmark of a disease called as corticobasal degeneration or corticobasal syndrome. So we can see here in this video that our gentleman is not able to use his left hand properly, or you can see the posturing, the dystonic posturing of his left hand and a little bit of dystonic posturing in his left foot as well. And the same person, we can see that he's struggling to use his left hand to pick up a coin, whereas he's able to do so with his right side. So there is ideational apraxia. He's not able to plan the series of motor movements on the left side. He's able to pantomime on command with his right hand, but when asked to do so with his left hand, he struggles to do so. So this is an example of idiomotor apraxia. So how do you diagnose corticobasal syndrome? It should be insidious onset, gradually progressive in people more than 50 years of age, and the main feature hallmark is the asymmetricity of the findings. The core features, more than 2 should be observed, and the cortical signs would be limb apraxia, cortical sensory loss, or an alien limb phenomenon. Extrapyramidal signs could be asymmetric rigidity, akinesia, dystonic posturing, or myoclonus as well. Supportive features would be a speech language dysfunction in the form of apraxia, frontal executive or behavioral changes, postural instability and gait disorder, and we should always exclude any rapid course, early autonomic failure, or early gaze palsy, or known alternative diagnosis. So PSP can sometimes mimic CBD in its presentation as well, progressive supranuclear palsy. So the management, other than the multidisciplinary approach like progressive supranuclear palsy, a levodopa trial should be given, and there is a very poor response to levodopa trial in this disease as well. For the dystonic posturing, if it is very severe, painful, then botulinum toxin injections can be tried. For myoclonus, we can try levetiracetam or clonazepam can be tried. Depression and apathy can be treated with SSRIs, and cognitive symptoms can be attempted to be treated by acetylcholinesterase inhibitors like rivastigmine and donepezil. Why it might work is because 50 to 60% of patients diagnosed with CBD on autopsy tend to have an amyloid pathology and cholinergic deficits as well. So it is worth trying these drugs, but there is no robust data to say that yes, they will work in them. So this is how the gross pathology looks like. You can see the stark asymmetric atrophy on the right side of this image versus the left, and you can see the surrogate ventricular dilatation. So this covers corticobasal degeneration. Now coming to the last case, which is a relatively new description of a neurodegenerative process, and Mrs. S, a 90-year-old retired teacher, presented with a 5-year history of progressive forgetfulness and word-finding pauses. So the hallmark to focus here on would be the 90 years, which is relatively older age group compared to the previous cases, and a very chronic 5-year history of progressive forgetfulness and of word-finding pauses. So her family has noted increasing difficulty recalling recent conversations, yet her social behavior and visuospatial skills remained intact. So there is only an amnestic single domain involvement and not a multi-domain involvement. Yeah. Okay, so there are no hallucination, disinhibitions, or motor features. So would anyone like to volunteer what the likely neurodegenerative process here could be? Any neuro residents who would want to answer? So maybe I'll continue. So on examination, she was alert and pleasant. She was oriented to person but not to date and recent events, implying an episodic memory loss. Naming and repetition were preserved, but she showed marked impairment on delayed recall and verbal learning tests. Language practice and visuospatial functions were relatively spared. So this was a clinical criteria for a new syndrome that is being described, which was published in 2024, called limbic predominant amnestic neurodegenerative syndrome, or LATE. So limbic predominant amnestic TDP43 encephalopathy. So the hallmarks of this disease was presented by the Mayo Clinic group who have identified this disorder, and the age group is typically older than 80 years. The core clinical features are an amnestic syndrome of the hippocampal type, so there is only episodic memory loss that is documented. It is an extremely slow progressive cognitive decline, and often without any other cognitive domain like visuospatial or language deficits. There is relative preservation of personality, behavior, and motor function early on, and the supporting features are an MRI pattern of atrophy involving just the hippocampal, the mesial temporal lobe, and the amygdalar atrophy. And the FDG PET might show hypometabolism on the limbic and medial temporal lobes. the amyloid tau PET or CSF biomarkers are negative or minimally positive for an AD pathology. So this is the presentation, a non-demented centenarian brain, which we can see here, some amount of cerebral atrophy, and the same similar centenarian brain with the late neuropathologic change. We can see that the hippocampus, the temporal ventricular slits here are widened compared to the normal one. So a selective pathology affecting just the hippocampus, which is a TDP-43 encephalopathy, is called as limbic predominant associated TDP-43 encephalopathy. So this is a very newly described entity. There is still a lot of research left, and we don't actually have data to suggest any treatment options for this. And because this is not a Alzheimer's driven pathology, there may not be any role of acetylcholinesterase inhibitors in this case. So I would like to end on this slide by showing a normal brain and by suggesting what my mentor has always been coaching about, that equanimity of mind, exercise, sleep, all these play a very important role in trying to help and maintain a healthy brain and keep neurodegenerative diseases away. So thank you, and any questions on this half? Thank you.